Good day, esteemed colleagues. My name is Michael Sabina, and I'm a PGY1 at Lakeland Regional Health Medical Center. Today, I present a challenging case that illustrates the complexities of managing a patient with multiple shock states and cardiac complications, specifically focusing on the difficult decision between percutaneous coronary intervention and coronary artery bypass grafting. We encountered a 75-year-old male with a history of type 2 diabetes, presenting with symptoms indicative of diabetic ketoacidosis, sepsis, and cardiogenic shock. His condition was further complicated by an acute myocardial infarction. This case was a classic example of triple shock scenario where interventions beneficial for one condition could potentially exacerbate another. This patient's initial management focused on stabilizing his septic and hypovolemic shock along with DKA. However, the cardiac component posed a significant challenge for us. Guidelines usually suggest immediate revascularization in myocardial infarction within the first 12 hours. Yet in this patient, the decision to delay revascularization was critical. This approach was supported by the shock trial findings indicating that delayed revascularization did not significantly worsen mortality in patients with cardiogenic shock. Another pivotal decision was the use of an intra-aortic balloon pump, despite the IABP shock trials indicating that there is no mortality benefit to using this device. However, it provided a necessary bridge in our patient, stabilizing him for 48 hours to address overlapping pathologies. The crux of our case centered on choosing whether we were going to use PCI or CABG. With a high surgical risk indicating a 20% STS score and the patient's overall clinical instability, PCI was deemed more appropriate. This decision aligns with the 2021 ACC, AHA, SCAI guidelines, which suggest CABG for patients with left main disease and a high syntax score. However, our patient's syntax score was below the critical threshold, and existing trials like Excel show no significant difference in major adverse cardiovascular events between CABG and PCI in patients with low to intermediate multivessel disease. The patient underwent successful PCI with multiple drug-eluting stents. Post-procedure, he showed remarkable improvement and was weaned off ventilator and intra-aortic balloon pump support. This case underscores the importance of individualized treatment in complex medical scenarios. It highlights the need to sometimes deviate from standard guidelines, considering the unique interplay of multiple acute conditions. The decisions made in this case, such as delaying revascularization, using an intra-aortic balloon pump, and opting for PCI, reflect a nuanced approach to patient-centered care in critical settings. Thank you for your attention.